Good evening to you. It's morning for me here. As you can see on the first slide, this is the house that one of the Mayo brothers lived in while he founded the Mayo Clinic. And we did also just have our first snowfall. So we are now entering the winter months here in Minnesota. I am very honored to be able to speak with you today about precision medicine for endometrial cancer. I was able to listen to some of the earlier talks, and I think a lot of this has already been covered, so I will go over this quickly because your prior presenters have done such a good job presenting this as well. So what I wanted to talk about today is three aspects of precision medicine. I wanted to start by talking about how we now use molecular features of endometrial cancers to classify them, and then I'll discuss the new staging system that was established last year, and then talk about biomarker selected treatments for endometrial cancer. So prior to the widespread use of molecular testing, as you know, endometrial cancers were classified on the basis of their microscopic appearance. By far the most common histology of endometrial cancer is endometrioid histology, and those were shown here on the top three panels. They are known as type 1 endometrial cancers in the past. And then together, the less common variants of endometrial cancer, such as serous, clear cell, and carcinosarcoma, make up the type 2 type of endometrial cancers. While this histologic method of classification served us reasonably well, it is limited by the fact that pathologists frequently disagree on the histologic subtype of the endometrial cancers. Additionally, it can be difficult to classify cancers that are heterogeneous or mixed, such as some portions of the tumor have one characteristics and other portions have another. Lastly, even when everyone agrees on the histologic subtype, there can be a wide range of outcomes so that the prognostic power of histologic classification is limited. We can make the argument that in the past, there was little need to change the classification system since we only had one treatment regimen to apply, the combination of carboplatin and paclitaxel. As such, precise classification of endometrial cancer didn't matter that much, but that has now changed. We now have a growing list of treatment options for endometrial cancer. We have hormone therapies that disrupt the balance between estrogen and progesterone. We have monoclonal antibodies and antibody drug conjugates that bind to HER2 and other antibody drug conjugate targets as well. And we have the immune checkpoint inhibitors that bind to leukocytes and potentiate the anti-tumor immune response. Each of these treatments works really well for some endometrial cancers and less well for others. Because of this, we are forced to ask new questions. Is the tumor hormonally sensitive? Does the tumor express the target for the antibody drug conjugate? And how immunogenic is this tumor likely to be? In the past decade or so, we've learned ways to answer these questions and others by studying the molecular composition of endometrial cancers. A major contribution came when researchers from the Cancer Genome Atlas, led by Doug Levine, collected tumor samples and paired germline DNA from 373 endometrial cancer patients. They performed the following testing that is listed here below, and then they performed unsupervised hierarchical clustering and found that the cancer separated into 4 groups. We have the POLE mutated or ultra-mutated cancers, the microsatellite unstable or hypermutated cancers, copy number low cancers, and copy number high cancers. Reflecting back on the histologic classification system, serous cancers are primarily found in the copy number high cluster, while endometrioid cancers are found in all of the subgroups. If we focus first on the POLE mutated cancers, we find they comprise only 5 to 15% of endometrial cancers, and so they are the least frequent subset. This subset is defined by the pathogenic mutations in DNA polymerase E or POLE. Because POLE is involved in DNA repair, POLE mutated cancers have impaired DNA repair, leading to an extremely high mutation rate. Because of the high mutation rate, POLE mutated tumors often have a high-grade appearance. However, they tend to be highly immunogenic due to the frequent formation of neoantigens, and as such, they have a very favorable prognosis, and we consider them to be a sheep in wolf's clothing. Shifting to the microsatellite unstable or mismatch repair deficient endometrial cancers, we see that these cancers comprise a larger portion of the endometrial cancers, about 25 to 30%. In these tumors, the defining mutations are in the mismatch repair proteins. These mutations are generally somatic, but they can be germline. Endometrial cancers with germline mismatch repair proteins are part of the Lynch syndrome, along with colorectal and other tumors. Although not usually as extreme as the polymutated cancers, mismatch repair deficient cancers tend to have a high mutational burden and are generally less sensitive to chemotherapy, but more immunogenic than other endometrial cancers. The copy number high endometrial cancers are also known as p53 abnormal, and they make up 10 to 20% of endometrial cancers. They are defined by the pathologic mutations in p53 and are characterized by frequent chromosomal amplifications, deletions, and translocations. Although they tend to be high-grade tumors, p53 abnormal cancers have a relatively low burden of point mutations. Most of them are serous histology, although clear cell and endometrioid cancers can also be p53 abnormal. And given the high rate of chromosomal amplifications, it's perhaps not surprising that we see HER2 amplification in a significant subset of p53 abnormal cancers. The last and most common subtype of endometrial cancer does not have a defining mutation like POLE, mismatch repair proteins, or p53. So many call them nonspecific molecular profile, or NSMP. These tumors do not generally have very many amplifications, deletions, or point mutations. The vast majority are endometrioid histology, and a large proportion express the estrogen receptor and may be estrogen driven. Interestingly, the distinct biologic subtypes of endometrial cancer often converge on many of the common driver mutations that they accumulate. Note that PTEN, PI3 kinase, ARID1A mutations are fairly common across multiple subtypes. Note also that many polymutated cancers may have p53 or mismatch repair mutations. However, when p53 is mutated, it influences the biology of the cancer much more than p53 or other mutations. So as such, if you have a cancer that has a mutation in p53 and one or more mismatch repair proteins, it's best grouped with the polymutated cancers. When the TCGA subtypes were evaluated for outcomes, we found that polymutated cancers, the sheep in wolf's clothing, were associated with an extremely favorable prognosis. Presumably, any microscopic residual disease after operation is cleared by the immune system. Mismatch repair deficient and NSMP tumors were associated with an intermediate prognosis, while p53 abnormal cancers portended the worst prognosis. Since it's prohibitively expensive and labor-intensive to perform multi-omic profiling of every endometrial tumor that we encounter clinically, investigators have developed a classification algorithm that can be used in everyday practice. Unfortunately, testing for polymutation presently requires next-generation sequencing. In practice, it is acceptable not to perform poly testing if the outcome would not affect the management. For example, if I were debating giving adjuvant chemotherapy to a patient with early-stage endometrial cancer, I would want to know the polymutation status. But if I were not considering chemotherapy, this test would likely not clinically be needed. We routinely perform either IHC for mismatch repair proteins or microsatellite instability testing via PCR in all endometrial cancer patients. And we perform IHC for p53 on all our patients. In those tumors that are p53 mutated, we check for HER2 amplification, first by IHC, and then by fluorescent in situ hybridization if IHC is equivocal. For NSMP tumors, we routinely test for estrogen receptor expression. If we now turn to staging, this has also become much more precise at the expense of becoming much more complicated. Prior to 2023, we could remember that stage 1 cancers were confined to the body of the uterus, stage 2 cancers invaded the cervical stroma, stage 3 invaded surrounding gynecologic structures or metastasized to regional lymph nodes, and stage 4 cancers invaded non-gynecologic structures or metastasized to distant sites. Now things have gotten much more convoluted, and it's hard to memorize the new staging system. I will mention that while I've just been talking about molecular classification, FIGO recognized that not all institutions have molecular testing available, so the new staging system relies mostly on anatomic stage and histologic classification of cancers. It's possible that this may change with the next iteration of the staging system. I won't go through all of the minutiae of the current staging system, but I think it is helpful to briefly highlight some of the key changes. The figure on the right shows the frequency with which stage 1 and 2 endometrial cancers changed stage from 2009 to the 2023 FIGO staging system. There are several key differences. First, if POLE testing is done and a tumor is POLE mutated, it gets its own category, stage 1AM, even if it would otherwise be a stage 2 cancer. Second, aggressive histio-subtypes, type 2 cancers, are upstaged to stage 1C if they are confined to a polyp and to stage 2C if they have any myometrial invasion. Finally, cancers with extensive lymphovascular invasion are considered stage 2B, even if they would have been considered stage 1 based on their anatomic degree of invasion. To frame our discussion of how precise classification and staging of endometrial cancers influence treatment of resected cancers, I'll start by highlighting how we have approached adjuvant treatment in the past. At that time, essentially all patients with stage 3 and resected stage 4 endometrial cancers were offered adjuvant therapy, while patients with muscle invasive stage 1 and stage 2 cancers might be offered chemotherapy if the cancer were one of the more aggressive subtypes. In all cases, chemotherapy, excuse me, I meant carboplatin and paclitaxel. In the era of molecular testing, most patients are treated similarly to what we did in the past, with a few exceptions. Given the poor prognosis of P53 abnormal cancers, we often consider chemotherapy for early stage P53 abnormal cancer, even if the tumor does not have serous or clear cell histology. Conversely, we might offer a patient with POLE mutated tumor observation even in a situation where we might have considered chemotherapy in the past. Finally, in advanced P53 mutated cancers that overexpress HER2, now we have data demonstrating the benefit of adding trastuzumab to adjuvant chemotherapy. In the future, it is possible that molecular classification may play an even larger role in dictating adjuvant treatment. The ongoing Rainbow trial performs molecular testing to stratify patients into 4 distinct sub-studies. Patients with POLE mutated tumors, the sheep and wolves closing, are randomized, but are not randomized, but are rather followed prospectively without receiving any adjuvant therapy. So these patients are de-escalated. Patients with immunogenic mismatch repair deficient cancers receive no chemotherapy, but are randomized to receive radiation with or without an immune checkpoint inhibitor. And patients with P53 abnormal cancers are randomized to receive chemotherapy followed by observation versus chemotherapy followed by PARP inhibitor maintenance. And finally, patients with nonspecific molecular subtype undergo testing for estrogen receptor, and patients with ER-positive tumors are randomized to receive radiation and chemotherapy versus radiation and hormonal therapy. We eagerly await the results of this multi-institutional trial to learn whether adjuvant therapy in the future will be guided by molecular subtyping. Shifting gears to the precision treatment of metastatic endometrial cancer, we'll first talk about the immune checkpoint inhibitor therapy. By now, we all know that immune checkpoint inhibitors, particularly those targeting PD-1 and PD-L1 axis, have transformed cancer care in an unparalleled way. However, we also know that not all patients benefit to the same degree from immunotherapy. Pembrolizumab was first demonstrated benefit for endometrial cancers when it was tested in patients with multiple types of mismatch repair deficient cancers. Here we see that nearly half of the mismatch repair deficient endometrial cancers achieved an objective response to second-line pembrolizumab, with a median progression-free survival of over a year. By contrast, patients with mismatch repair proficient endometrial cancer had just a 15% of responding to pembrolizumab monotherapy. Luckily for these patients, the combination of pembrolizumab with the VEGF2 inhibitor lenvatinib provides a more meaningful benefit, with approximately 40% of mismatch repair proficient patients responding to the combination treatment, an improvement over second-line cytotoxic chemotherapy. More recently, investigators have evaluated immunotherapy in the front-line setting for patients with metastatic or unresectable endometrial cancer. In the RUBY trial, patients were randomized to receive the anti-PD-1 antibody dostarlimab or placebo. Those receiving dostarlimab had a benefit in both the progression-free survival as well as overall survival, with a greater degree of benefit seen in patients with mismatch repair deficient endometrial cancers. Similarly, in the NRG-GY018 trial, the addition of pembrolizumab to first-line therapy led to an improvement in progression-free survival. Again, the greatest benefit was seen in mismatch repair deficient patients. Given that not all patients achieve durable disease control with immunotherapy, it is encouraging that we have also seen significant advances in the targeted therapy in the form of antibody-drug conjugates. Similar to the study of pembrolizumab in mismatch repair deficient patients, trastuzumab deruxtecan, an antibody-drug conjugate targeting HER2, was tested in a biomarker-driven fashion in patients with many tumor types. The arrows show the objective response rate and survival outcomes in patients with metastatic endometrial cancer with 3+ or 2+ HER2 expression by IHC. Based on this study, trastuzumab deruxtecan was approved in the United States for patients with HER2 3+ positive tumors. I will note that while p53 abnormal tumors are enriched for HER2 amplifications, we do sometimes see HER2 amplifications in other subtypes. So it is reasonable to test for HER2 overexpression in any patient with metastatic endometrial cancer. Last but not least, I would like to briefly mention hormonal therapy for metastatic endometrial cancer. We have long known that a subset of endometrial cancer patients benefit from drugs that either increase progesterone levels or decrease estrogen levels. More recently, we have learned that cyclin-dependent kinases drive proliferation in estrogen-sensitive tumors, and CDK4/6 inhibition can provide benefit for patients. Here we see that the CDK4/6 inhibitor abemaciclib combined with the aromatase inhibitor letrozole can lead to a durable response in patients with estrogen receptor positive endometrial cancers. Similarly, my colleagues at Mayo Clinic tested the combination of ribociclib and letrozole in ER positive endometrial cancers and saw multiple prolonged responses. In the United States, these regimens are now endorsed by the National Comprehensive Cancer Network. To summarize, we've learned that molecular classification of endometrial cancer has value both in determining prognosis and predicting benefit from cancer treatments. We've seen that the new staging system is extremely complicated, but is more precise than the prior system in providing prognostic information. We've learned how molecular classification might help us better select which patients benefit from adjuvant treatment, as well as which treatments are most beneficial. And finally, we've seen how we can use molecular testing to tailor therapy for patients with metastatic disease. So thank you so much for your time, and I'm happy to answer any questions.
Thank you so much, Dr. Andrea. Any questions anyone wants to ask? One question, 1 minute.
Trastuzumab, exactly which setting you can use, ma'am? Like upfront adjuvant we can use, or only recurrent and metastatic if we have adjusted the tumor?
So if I understood, I only heard a part of that, I'm sorry. So is the question, how do we use trastuzumab deruxtecan?
Yes, ma'am.
When do we use it? He's asking what are the indications?
Yes. So currently we're only using it in the metastatic setting, so in the recurrent setting. So currently our frontline therapy, kind of depending on, stage at diagnosis, is either the chemotherapy plus or minus the immunotherapy. Or we do in those that are HER2 positive, you can add Herceptin to the upfront treatment with the chemotherapy. We occasionally do that. But the trastuzumab deruxtecan currently is only in the recurrent setting. So we tend to use it as second line for those that are HER2 positive.
In P53 mutated, those group of patients are all HER2 because HER2 positivity is more in P53 mutated recurrent endometrial cancers. That is where HER2 is more indicated, or you can all recurrent metastatic you can just do it now?
Yes, so we will test for HER2 expression prior to using it. I would say you're right. I mean, it is much more frequently seen in the P53 mutated. That being said, we test all of the, recurrent endometrial cancers for HER2. I would say maybe, less so in the low grade histologies, but in the high grade histologies, at least up front. In the low grade histologies, we often will turn to hormone kind of manipulation first. But I think it's worth testing all of them because we have seen endometrial cancers that, are not P53 mutated that do express HER2. I will also say, in the United States, the current label is actually for HER2 positive, 3+ expression. We, as you're aware, the data in breast cancer really suggests, you can even use trastuzumab deruxtecan in kind of the ultra low. We don't know exactly how low we can go in endometrial cancer, but we've also seen in the data that the 2+ shows some efficacy. And so I think where we're going to need to kind of tailor things is to better understand kind of what is the true cutoff for using the drug. And I would say we have used it in those that are 2+ positive as well. And we're thinking about, especially in some cases where you don't have additional treatment options, we have been able to use it in the 1+ as well. But in, the actual indication right now, at least in the United States, is for 3+.
Thank you. And one last question. Do you use chemoimmuno even in upfront as a NACT in advanced metastatic endometrial cancers?
So do we always, yes, we have transitioned to using chemoimmunotherapy for many of our adjuvant patients. In the mismatch repair deficient, we do. In those that are proficient, there is a suggestion there there is an improvement in PFS. It's just not quite as pronounced. So we, in those cases, really talk about the pros and cons of the treatment, the side effect profile, really look a little bit more into their actual stage, their risk factors, their age, their comorbidities, and think about whether it would be worthwhile to add immunotherapy at that point.
Thank you so much.
Thank you.
So it's been great hearing you. Thank you so much for waking up early in the morning and really enjoyed it. Okay, one more last question.
Dedifferentiated tumors were traditionally called as highly aggressive, but we commonly found they are MMR deficient tumors. So how do we treat them? Like in any normal MMR deficient, or like the previous histological based aggressive tumors?
Yeah, I think, it's interesting. I think as we are learning more and more, and I think this is going to continue to change and evolve, but I would say we have now transitioned or rely more on kind of the molecular classification and kind of, like you had mentioned, kind of going through the algorithm of assessing, POLE status, mismatch repair status, P53 mutational status, looking at those more so than the actual, histology, because, for example, some of those POLE mutated cancers can look very aggressive on under the microscope, but then you see that POLE, signature, and then we can sometimes de-escalate treatment. So I would favor, if you have a tumor that's mismatch repair deficient, regardless of what it looks like. I mean, it's kind of in that middle field, right? So it's not, if it doesn't have a P53 mutation, it's probably kind of in that middle road, and looking at using immunotherapy in that individual.
Thank you again. Thank you so much for all the inputs and answering all our questions. Thank you, Andrea. I'll keep in touch with you.
Yes, thank you very much. It was great speaking with you all.